everyone. So now we are going to start the most awaited IC of AIOS, the Cataract Armamentarium, and we will talk about everything from ECCE to femtolaser. So at the outset, I would like to invite Professor KPS Malik. Okay, sir. So in this IC, we will talk about ECC, then SICS, and then we'll talk about Phaco, then migration of Phaco surgeons to SICS, the multifocality achieved through SICS, and the femtolaser surgery. So let's start with Professor Ruchi Goyal, ma'am.
So I would be, thanks Pratyush for including me in this instruction course, and I would be talking about the basic concepts, that is what are the basic steps that you really need to learn perfectly to perform a good SICS. So the special indications where I would choose SICS as my first choice would be a high astigmatism, because simply by changing your size of the incision and the site of the incision, you can deal with high astigmatism till up to 3 diopters. If there is an extensive corneal opacity where doing a phacoemulsification is next to impossible, rocky hard cataracts where you don't want to jeopardize your endothelium, or a calcified anterior capsule where a complete rhexis is not possible. Now, just look at these patients. I had this patient which had a sclerosing keratitis all around. Where would you put your clear corneal incision in this case? So you have no choice but to do a SICS. This is a patient with radial keratotomy marks. If there are, if the marks are about 16, then you can go ahead and do a limbal incision. But if sometimes there are multiple marks and there is absolutely no place where you can make your clear corneal incision, then there is no choice but to go for a scleral incision. This is a patient of marginal degeneration. Again, there is no area where you can put your clear corneal incision. Now, there would be cases where there would be a contraindication for making a scleral tunnel. So look at this case. This is a scleral thinning, and this was caused by a sclerouveitis, recurrent sclerouveitis. This is a pre-existing bleb where you have to alter your site of incision. You can still go ahead and do a scleral incision, but not here. Now the types of incision, whatever incision you are going to make, whether it is straight or frown or whatever, it has to be made in such a manner that you create a tunnel which has a single plane. Don't create a tunnel which has multiple planes. The other thing is your internal incision has to be larger than your external incision. So as we divide the funnel into 3 parts, this is the external incision, this is the internal incision, these are the side pockets, and this is how you dissect. So now this is a imaginary area which was described by Dr. Koch, that is the incisional funnel, and he stated that any incision which is placed within this funnel would induce the least amount of astigmatism. So clearly you can see the more closer you are towards the limbus, the more astigmatism you are going to induce. One is that you are going around like a curvilineal incision, it's going out of this funnel. The second is that if you want to enlarge this tunnel, how do you enlarge? So the only option is that you move backwards. So that is how the frown incision came into existence. And to further add, now we have started doing 2 straight backward cuts on the same frown incision. Whenever you do the dissection internally, now let us see, you have made a good frown incision here and you have dissected internally. This should be about 2 millimeter, 1.5 to 2 millimeter. Again, this should be 1.5 to 2 millimeter. This should be about 8 to 9 millimeter. And the external incision is going to vary. The size is going to vary depending on the kind of technique you're using. If you're using a technique where your entire nucleus is brought out, obviously your external incision has to be larger. If you're using a technique where your nucleus is going to be broken either inside the NTA chamber or in the tunnel itself, then your external incision can be smaller. But there are claims, a lot of surgeons are claiming that they can do it in 2 millimeter, 3 millimeter, but advisable would be at least 4.5 if you're doing a Phaco fracture, minimum I'm talking about. Otherwise, I would go for a not less than 5 or 5.5, and if need be, if it's a very large nucleus, I would increase it sideways and increase it to 6 or more. So it is the safety which is more important rather than, you don't have to show your heroism anywhere. Now, these are the different techniques which have been used by different surgeons, and I think in the subsequent talks there would be a description of some of the techniques, and I would be showing you the Blumenthal technique. So this is a Cataract nigra, and nowadays what I do is I leave a frill of conjunctiva near the limbus so that you don't harm the stem cells. And it also helps in closing your wound properly. The wound gets covered by it. This is a frown incision, and this is the 0.5 millimeter depth of the external incision, followed by a crescent knife being used to dissect further into the cornea, about 1.5 to 2 millimeter. It is very important to use blades that are sharp, otherwise you don't have a very good dissection. I create 2 side ports nowadays instead of 1. It helps in stabilizing, especially if you're trying to do a topical, it helps in stabilizing. And this is the rhexis. Now remember, the size of the rhexis corresponds to the size of your nucleus. If you have a nucleus which is very large, don't try to make a small rhexis. By and large, your rhexis size has to be 6 millimeter or larger in SICS, but if it is a very large nucleus and you make a small rhexis, you will end up doing an intracapsular cataract extraction. If by chance you have ended up creating a small rhexis, you need to enlarge it further before you go in for prolapsing the nucleus into the chamber by giving 2 tangential cuts. Now, this is the anterior chamber maintainer. We hold it very close and fix it. Now see, the side port is used to stabilize the globe, and you enter and you always cut with the keratome in a forward direction. It is important to dissect laterally because this is where the nucleus is going to engage. After that, a good hydrodissection is done. If your size of the rhexis is corresponding to the size of the nucleus, the moment you try and do your hydrodissection, your nucleus will start popping out. Then remember to inject viscoelastic because this is a hard cataract, you don't want your endothelium to be damaged. So you inject viscoelastic in the front and by the sides. This is a Sics hook being used to dial the nucleus and prolapse it out. So once one of the edges is out, you can inject viscoelastic on the surface of the iris. That will help in pushing the nucleus out further. You can also use different other techniques like hand over hand maneuver. So before the this is now the hand over hand maneuver being used to prolapse the nucleus out. It is a large nucleus with slightly smaller rhexis than what it required. So this maneuver helps. And again, lots of viscoelastic in front. After that, this is an iris repositor which is placed behind. I keep pressing on the sclera. The fluid is on. And the needle in the other hand is chipping the nucleus so that the nucleus becomes smaller in size. As the nucleus becomes smaller in size, you can keep on pushing the nucleus back to engage the smaller diameter. And eventually, as the nucleus engages into the internal tunnel, suppose the nucleus does not engage, that means your internal opening has to be enlarged. Now see, the nucleus has become smaller. I again inject the viscoelastic and re-engage the nucleus. Keep chipping it to bring it out. This may take a little longer time, but it is important that you must make an extra effort to keep on injecting viscoelastic, otherwise your endothelium gets damaged. Now once the nucleus is out, I don't use a Simcoe cannula, I just use the same cannula of what you use for high vis, that cannula through the side port with the interior chamber on and aspirate the cortex. This is especially useful for aspirating the 12 o'clock cortex. You can see how easily, without any injury to the posterior capsule, you can go quite behind. And there is no chance of collapse of the chamber. You can put the IOL either under fluid or under visco. Nowadays I prefer to do it under fluid only with ACM on. Now see, this is a patient where the CCC created was smaller. This is the tangential cut I was talking about. And this is the Utrata's forceps. You can just simply enlarge it. Another cut on the other side. Now look at this patient. While I was doing the dissection, something went wrong. Can you see that dimple coming in? The moment you do a premature entry, see now the striations have also come. So that means you have had a premature entry and you stop there and then. Inject viscoelastic, complete your steps, and then the further enlargement needs to be done with the keratome, because at this stage if you do something, you are going to create a ragged wound. So never try to dissect when your eye is in a hypotenuse state. That is the most important thing. Inject viscoelastic. Either if you have done it at a very early stage, then you can inject viscoelastic, take another plane and start dissecting your tunnel in another plane. Otherwise you just do it with a keratome. Now this is another case where again there is a premature entry and the nucleus, while it comes, it may has a tendency for the iris to get incarcerated beneath the nucleus. So if your nucleus is not progressing and you have a doubt that there is a premature entry, then don't try. This is what you should not do. See what is happening now. So you just push back the nucleus, put in viscoelastic, re-engage your nucleus and then take it out. Otherwise you will end up with a superior iridodialysis if you keep on doing this. Now this is a situation where there is a buttonholing of the roof of the tunnel. So what happens is, as you inject as the fluid comes out, it keeps coming out through those ports, and again a leaky wound. You can see if your side ports are large, you can have a leaky wound. So what you need to do, you should suture these kind of tunnels wherever your wound is unhealthy. See, the superior wound is so ragged, so you need to suture these wounds. So never leave a leaky wound unsutured, because it's not about not suturing the wound, it's about giving a secure wound. That is most important. So thank you so much. Anything anybody wants to ask, most welcome. Thank you, Pratyush.
Now Professor KPS Malik will talk on modified ECCE. And I would request Professor Ruchi Goyal ma'am to please come on the dais. The chair is waiting for you, ma'am.
बंद कर देना, बंद कर देना. यही है ना? Sorry, this looks little outdated, but I do lot of camps sometime, and you SICS sometimes is not easy that you can do say 50 patients or 150 patients in 2 days something. So I have tried that. Modified ECC means it is ECC which anybody can do, and cover it with 280 suture which are removable after 9 days. So first follow up, do it after 9 days and remove these sutures. So this is what I do in one of the camps where I do the fast surgery. I do the rhexis, take the nucleus out, do the hydro, do everything like you do in ECC. Only thing, the incision is fixed 8 millimeter at limbus, no conjunctival flap. So this becomes a very simple surgery. Only thing, and this 8 millimeter is a biplanar incision, not the triplanar, not the SICS wala tunnel, but biplanar, which would not leak, would not have a iris prolapse, but I would cover it with 2 sutures because I don't want ATR of more than 1 or 1.5. And so this is just a video. Please शुरू कर दी पीछे करके थोड़ा सा नाम दिखाइए पहले क्या है लिखा कि नहीं कुछ टाइटल वाइटल वेयर इट स्टार्ट्स नहीं आगे मेरा नाम वाम कुछ नहीं लिखा गया इसमें नहीं अच्छा चलो so this just run it so with it you can Bart Parker knife or you can have a 2.8 and make a little incision then do the rhexis. So this is a hypermature cataract with milky this one, and generally I use bimanual rhexis in these patients, which I have published also. We have published that left hand port is teach you to learn Phaco. So whatever surgery you do, make two ports, one right, one left, and SCCS also. Once I have made that biplanar, and when you put a seizure, it will cut in biplanar only. It would not be monoplanar. It would not be uniplanar. So this is a just 8 millimeter incision, limbus only, and no conjunctival flap, little hydrodissection, so that nucleus is freed. You don't have to rotate it. You can take it out by the sandwich method. You can flow it out with the visco. You can take it with the irrigating practice, whatever method you want. But this will be a less than 2-minute surgery or 2-minute surgery maximum. And then routine aspiration, there is a bag, so you can put the lens in the bag. So this is meant specially for my camp surgeries. And I feel that my one ex-senior resident is working there in that place where I work. This is a permanent eye hospital and he does now every 15 days or something. So he does everyone's ECC, the SICS, but he makes nearly 8 millimeter incision in SICS. So that I am never happy. 8 millimeter incision in SICS, left unsutured, will reduce loss of astigmatism, but he does that. And I cover this area is covered mostly by, you can cover it with one also, but I generally take 2 sutures, and 2 sutures is cover it perfectly. And I tell you and believe me that 10-0 nylon induces so much of the vertical myopia. So you get a -3 cylinder, -4 cylinder at 180 when you are doing 10-0 suture, deep 10-0 sutures. I have done a study on research, I have done a thesis publication that 8-0, I was doing 8-0, then 10-0, then 8-0, 10-0, alternate 10-0, alternate 8-0 and alternate 10-0. So that will control, the one will produce hypermetropia, one produce myopia. So if you do that, alternate 8-0 and alternate 10-0, that also is good. But these 2 8-0 sutures are there, and you can remove them in a first operative follow-up, which you do at 9 days or 10 days. So this is, I say, is a fastest and a good enough surgery. Take the knot backward, not in the cornea. And silk doesn't hurt like a 10-0 nylon. Silk doesn't produce, the 8-0 doesn't produce the papillary hypertrophy. So thank you very much. This is just a small something for when you do large surgeries, and gives very good result. And you learn the hydro, you learn the rhexis, you learn everything with it. Thank you.
So now we are going to learn MSICS for the Phaco surgeons. Yes, you have read it right. From Phaco to SICS. So first, let's differentiate between the facts and the myth. Many people think that Phaco is a new technique, SICS is an old technique. Phaco is a good technique, and SICS is not so good technique. So Charles Kellman, he introduced Phaco in 1967, whereas Blumenthal did it in 1992, a good 25-year gap. So SICS is 25 years younger than Phaco. And now let's get off all this preconceived notions of which surgery is best. No surgery is best. You have to choose right surgery for right patients. Like I would encourage everyone, including especially the young residents, which procedure would be best for this patient. Let's raise hand for A, for B, for C, and for D. Okay, so as by counting the hands also, it was SICS which could do justice in this case. And suppose it's an old patient with this kind of plaque and cataract grade, SICS would definitely do a better visual outcome. It will give a pristine cornea, especially on the next day. And now this, how many for ECC on this patient? A, raise your hands. B, SICS. C, raise your hands. And what about D? So yes, the most will do a Phaco in this patient because we want a closed chamber, and Phaco will deliver a good result in this patient. And what about this? A, how many? B, C, and D. Yes, this is a clear-cut case for D, I think, because the only problem in this kind of cataract is rhexis making. It will go haywire, it can run anywhere. So flux will do a wonder in this patient. Once you get a good rhexis, you can do it. And what about this last one? A, B, C, D. Yes, I think again it's D and probably combined obviously with C. So this is how we choose correct method for correct patient and correct cataract grade and situation. So no technique is perfect. Everything has its drawbacks. So we have to choose the right method. And for that, you must learn everything from the modified ECC, which Professor Malik just explained, till femto probably, yes. And what you will do in this, suppose you are doing Phaco and you land up in this. So now, who will save you? Probably SICS. So which anesthesia is best for SICS? Because from Phaco, when you are migrating to SICS, this will be the most trickiest part. You are habituated in doing topical and suddenly your patient eyes are moving, you are not able to make the tunnel. So which is best? So initially it is obviously peribulbar, start with peribulbar. Once you are confident in SICS, you can always do topical. In most of the patients you can do topical. Obviously you have to select, it cannot be like I do topical in all, it cannot be like that. It has to be patient preference also and his pain threshold bearing capacities. As everyone is agreeing now that it can be done topically. I am doing topical SICS since last 5 to 6 years. No problem at all. Even you can do cautery in that. Patient does not feel pain. The block is at the surgeon's mind. It does not be required at the patient's eye. So now let's have a look at a video. It's topical. And it's transconjunctival, and I'm doing a modified customized incision because it was steep axis was temporally, so I'm doing a temporal incision. Initial this part may be difficult for beginners, especially under topical, but once you achieve the second plane, then things are absolutely smooth. And it's just a matter of practice and patience. So I would just fast forward it little bit. Pockets should be well made in SICS because it's a snake mouth kind of tunnel you are trying to create, in which the inner pockets are larger than the outer incision. So this is the pocket making. Now I do 90-degree this capsular axis using Utrata. It gives me better control, better hold. Then entry. This is the most important part. It should be in a straight line on Descemet's. Hydro like you do in Phaco. The only difference is we try to pop it, because once it gets popped, half of your troubles are gone. And then, as Professor Ruchi Goyal has explained various methods of nucleus delivery, you can use any one which you like. You must try everything before settling on one, because again, as I told you, you will require different set of skill for every patient. And you must deliver best for each patient. And that you can only do when you know everything. So this was a simple hydro expression of the nucleus. And after cortical cleanup, using both ports, I do a hydro implantation. You can use a PMMA lens also. It depends on patient's choice. They want sometimes better lenses, and sometimes it's difficult to argue with them that PMMA is better than most of foldable. And one more myth, you can implant a multifocal or something like that in SICS also. But once you should be comfortable of your SIAs. So again, the other thing in topical SICS, or when you are trying to convert from Phaco to SICS in between the surgery, you can use this marker. This marker is very helpful. Just a little small video. The same video which we saw today. I'm from Varanasi, and this is famous Varanasi Ghats. So this is Ranjan marker. It has a serrated edge which holds onto the globe, and now you have this stencil-like thing which will give you a frown-shaped incision of 6 mm. You can increase it, and the rest of the surgery is almost same. So if you are not comfortable with a tooth forceps, topical Phaco, topical SICS, you can use Ranjan marker, and this would help you in creating a good tunnel. Thank you very much. I would appreciate any questions.
Only Pratyush, this is, yes. Mike, till then I ask, Pratyush,
Sir.
This is a marker you designed well. I tried it, you know, but only thing is, I think very good idea to have a transconjunctival incision and going to sclera and then tunnel making. I think then you save a lot of conjunctiva and you save a lot of stem cells. But conjunctiva clean cutting in old people is difficult.
Yes, sir.
That straight line cutting of a conjunctiva in old person, because it is lot of looseness, and making it a straight cut through your marker also, sir, I find it difficult sometimes. Either I hold it and then make a small cut first in conjunctiva, and then you use your marker on the sclera.
Yes, you can do that also, sir. But again, yes, like all skills and all surgeries, nothing can be 100% for every patient. We have to be
You solution for conjunctiva only.
Yes.
That conjunctiva cutting, how you make it simple?
Yes.
That does it cut with the marker well?
Yes, sir.
You have cut it well. I could not.
It's just practice, sir. Just practice.
Yeah. So this marker has another good thing is that you can go any angle you want. It has angles also. So use this marker. It must be available.
Yes, sir, at Epsilon counter. Epsilon is marketing it.
हाँ बेटा बोलो.
Sir, the thing about the
अपना नाम बताओ और कौन से शहर के?
Myself, Dr. Arpit Sharma. I am from Dhar, Madhya Pradesh.
Good.
Sir, about the transconjunctival flap, shouldn't we take the flap and then give a scleral incision to reduce the risk of infection, because conjunctiva also helps to reduce the risk of end off and all.
Once I do transconjunctival, I'm sorry I didn't show you the last slide. Can I have this video again? Please allow this.
क्या कह रहे थे आप? Problem with the conjunctiva is that you lift the conjunctiva first.
No,
Yes,
no, he is not excising the conjunctiva. He is simply obviating one of the steps. So the conjunctiva is going to be there to cover your wound. So don't get worried.
Yes,
about
and
it.
at the end, I'm
Yeah,
quartering it. I just want to show that video, please. Console,
And
yes.
only thing is, like, it's a little difficult to sometimes dissect with the conjunctiva on. So you just notice continuously there was fluid being poured onto it, so that you have a very clear view of where his plane is. That is one thing which is difficult if you have a conjunctival flap covering your sclera.
So why there is a need of transconjunctival? Why shouldn't we?
He's, just to make your surgery faster.
Just a different technique, just
Just
a
that's
different
all.
technique. Again, I'm telling you, all techniques should not be applied like blindly to everyone. But what are the advantages of doing a transconjunctival? First, it saves you limbal cells. Second, it saves cautery. And, over cautery can induce astigmatism, scleral melts. So it saves that time, and little bit of bleeding actually helps in good seal.
Sealing.
And actually, little bit of bleeding will cause such adhesions that your bacteria won't enter. And, just see the last step. I think I forgot to show that. So how I am covering that conjunctival wound. The sclera is self-sealing.
Injecting saline?
Yes, sir.
Don't inject antibiotic on this area.
Saline.
This is my advice, that because you have opened the wound, any genticine going into the chamber, vitreous will produce optic atrophy. Please, if you inject any antibiotic, do it at 6 o'clock, side anywhere, but never at the site where you have injection. If you want to inflate the conjunctiva the way he did, it can be done by saline.
See, this is how I close. If just hold both the end and do a little bit of cautery.
And SICS also, like, you can do without cautery, really. Bleeding takes its own time, and by the time you are through with this SICS, your whole bleeding has stopped. Initially on microscope it would look bad, that there's a hemorrhage there, there's a clot there, this one. Once you clean that up, everything is so good. And in fact the fibrin which has been produced, as he said, that will close everything so well. Conjunctiva will sit back, the sclera will sit back, and doing SICS without cautery is wonderful.
Thank you, sir.
Won't get a problem.
Thank you.
Any more questions? So I would invite Professor KPS Malik sir again to talk about ABC of Phaco. I learned Phaco from him. I learned SICS from him. And it was wonderful experience at Safdarjung. First year PGs would do ECC, second year SICS, third year Phaco.
So I am at Rishikesh AIMS now, and half of country have students like this. And Aniket was one who is in this video working as an actor. It's a extempore. We decided that day that we will make ABC of Phaco. So we remember 5 P's: proper preparations prevents poor performance. So make sure what you are going to do. That don't decide on the spot. I can decide on the spot, and I sometimes regret. I should decide beforehand, this patient, what I have to do, which kind of flap, where, site, and all that thing. So be prepared that, and always be sure about that you have put the betadine in the conjunctival sac at least before 10 minutes or 5 minutes we say, but in fact we put sometime 20 minutes before. My resident do that, but generally 10 minutes is good enough to do it, and not the 10%, not the 10%, does somebody advocate that? And then you have case selections, and you should know self-sealing inlet during SICS, capsular opening you must have learnt, hydro procedures, you must have learned SICS. Working of Phaco machine, you must learn outside the eye, nuclear handling. So SICS is this, which tells you all. Instructors intend to take you to Phaco surgery as parents took you to the cycling without hard falls. So there will be falls in the Phaco learning, but when you were teaching cycling to your child, you were holding him for a while, for a few days, and then you were, without telling him, leaving him. So then you expect that he will fall sometime. So the fall, when he has learned cycling, will be soft. If he has not learned cycling, he might injure himself. So this is what all about learning. Case selection is Phaco. Choose an eye which is prominent, has deep AC, fully dilated pupil, grade 2 to 3. So beginners should not attempt the very soft cataract. Soft cataracts are very bad for Phaco. Hard cataracts are very bad for Phaco. Soft cataracts, you cannot rotate them. They will just cheese wire, whatever you do. Even in SICS, the very soft cataracts are very bad. My complication mostly in SICS is a soft cataract, when you cannot take out the nucleus out. So you have to do multiple time of hydrodissection, secondary, tertiary, whatever time you do dissection. And speculum is one enemy you must recognize. Speculum sometime in Phaco would not allow you to enter what you want to do. It comes in between you. So see if it is with the screw, sometimes that gives a better opening. But then you must have that don't come in your way. I do superior temporal on right side. I do left side superior temporal, but sit on the left side like this. So I sit there. I don't sit at 12 o'clock for left eye at all. If I want superior temporal on the left eye, I must sit here. I make one port here. And then you must have the right-handed that where I will be comfortable making my incision. So when you are making superior temporal on the left side, sit on the left side little. So patient comfort is, this doctor is again, I think, very famous doctor in Banaras now, and Aniket is sitting here, this tall man. Patient comfort and your comfort is very important before starting the surgery, any surgery. Check your pedals, check your IPD, check your everything. No palpitation before starting surgery. Phaco में palpitation पहले ही शुरू हो जाएगा तो टूटेगा ही, फिर तो गिरेगा ही कुछ ना. So make sure that you're focusing, your seat, your height. When you sit there and then you say, call me, take me up, take me down, that thing should not be done. Before patient you have started, make sure that your eye, your brain, your focus, your deep breathing, comfortable. Then you start Phaco. And Acharya Kelman said, no alcohol 48 hours prior to Phaco surgery. He told that, I don't know how many of you follow it. I follow mostly. That I avoid alcohol always before surgery day, 24 hours at least, not 48 hours. And now, of course, I virtually giving it up. Like, I'm not coming to night parties here these days. I taught you all dancing, but I don't dance now. Learn these things. You need both hands for Phaco surgery. Your steady both hands are must. This simple technique you will see in a village mela. So put one wire, put one chabi, and उसमें तो क्या होता है, current आता है, आवाज करता है. Once it touch, you can buy that. You have a wire and a battery which tells you if you touch it, it will make a sound. So learn to put this key like this without touching. Here, and left hand. So bidextrous, learn the steadiness of fingers and this joint, and use the wrist. Wrist is one which is required in Phaco, not the elbow, not the kanda, not at all. So learn that in the child, means whatever way you learn, left hand during SICS, left hand wherever you can. And these things should be done well before you are going to do Phaco. This doesn't require money, it doesn't require anything. Only thing I found it lethargic. You tell them these things, they just laugh it away and go away. We'll go to see the movie, but don't do this exercise. I give them a foil, Rexis, make the Rexis mark on a foil, aluminum foil. Tighten it on a bottle, wide bottle. It makes beautiful rexes. And once you do the 50 rexes like this on a foil, your fingers, you will know that you are moving where. And put a red butter paper under that foil, you know the red reflex also. So learn the rexes outside the eye. Learn hand-eye coordination in artificial eye outside. That if you can have a wet lab like this, then it's much better that you learn it outside. You learn suturing on thermocol. This is artificial eye where you can learn rexes, where you can learn the Phaco the trenching, where you can separation you can learn. There was here I was trying to teach yesterday in the here wet lab, but you know even one candidate to take, it will take 1 hour to teach this setup. So ये बना तो दिया setup, but ये सब फर्जी है, नकली है. It's not really doing much to you. Teaching here is very difficult. Wet lab, how can I teach the Phaco to someone in the cabin, though there is an instrument and 3 water bottles have gone in one person or 4 water bottles have gone down, because beginner cannot virtually control things like, and this artificial eye is not a bag, it's not a capsular bag. So it tends to flow anywhere, but it gives a very good feeling of the nucleus, that you can do the trenching and you can learn both foot use, you can learn the artificial eye doing something, Phaco learning, is very good, very, very good. It costs 110 rupees, and this simple one I thought of, that left hand use, put a chapati in a fixed something, you can improve on it. Take a plate where chapati or paratha is fixed, like rexis, like a lens, it's not moving. So once you put that and left hand you rotate it, you will learn to rotate. So then, you know, when we rotate the nucleus in Phaco, we don't push. We must rotate. We must not pull it like this, we not push it like this. This technique of eating the chapati, rotating it, eating it, rotating it, cutting it, rotating it, cutting it. You will learn the Phaco virtually with the roti. Okay? Do that. Understanding dynamic fluids and mechanism of Phaco machine, I think you must have known. Phaco has got a piece which has to break the nucleus, and it has a irrigation, it has a vacuum, it has a aspiration flow rate, and power to break it, power to break the nucleus. These are components of the Phaco, and outflow is what you fix like 20 cc per minute. But take into account, allow me a time, I can go on? Yes, sir. Okay, so there is extra flow from the side ports and all that. So I try to make it shorter, but so a device to break it, wet lab, learn as much as you can. And this is, of course, simply tells you that it is a bottle and one tube this and the Phaco, where the outflow and vacuum. All old machine has this one, and you have to set them. But like Century, you have to set only tension. That I will do Phaco at 30 millimeter of mercury, so it decides every parameter itself. So that is what the new machines have done. But old machine, what you have, Ortly or AMO compact, I can do still any kind of cataract. I have learned now that I can raise the 500 vacuum and use the minimum energy. So basic is can be done by anything. So main function, irrigation, aspiration, emulsification, pumps. You know that there are peristaltic routinely in all machines. There is a vacuum, hardly used these days Venturi pump, because these new pumps are peristaltic, safety of peristaltic, but with a very short time rise. So they work like Venturi. So once you catch a nucleus in these new machines, it will catch up very fast. And then you can do chopping or whatever chopping you want to do, chop and stop or divide and conquer, whatever you want to learn. Direct chop, don't think for much more time. I found virtually no big advantage of direct chop when I compare the timings, because making trench, making 2 pieces, bringing it up samne, one cotyledon, and then doing the virtually vacuum eating. No Phaco using, virtually no physics, you just use few pulses. So direct chopping in a hard cataract is a very, very big risk, because there is no movement place in the bag. So direct chop in a grade 5 cataract, you have to catch it under the little middle se down towards the 6 o'clock.
Console,
and then you have to
console, allow the video to continue. Console, allow it.
It has a video? No, I think
sir, your
आगे होगा
presentation.
शायद। आगे है शायद कुछ something. This is the new pumps which we call the scroll pumps. That scroll goes like this, inside scroll goes opposite side. So this maintains the chamber. This maintains the chamber, and these are in newer machines like Infinity, Centurion, etc. But our old machines are peristaltic, but they also have a virtually now better control, surge control, and basically it is a machine like your clutch and brake in the car, that you learn that I will press it how much, small, this, so you can control your everything, vacuum and everything. Say this is Infinity a soft, it's a motherboard of console, so it has a commands on foot pedals and everything, and it has a torsional and a straight both. So if you have these, not necessary that you have to this. I generally don't recommend that you must have it. Absolutely not. You basic, all these years, till I was in Subharti, I used the basic machines. Now in AIMS Rishikesh, we have got Infinity. But there also we have got a now AMO, which has been sold to, I think, Johnson & Johnson, a machine which has got again power, outflow, and the vacuum, which is under my control. So that gives me better. Still, I am much happier with those kind of machines. So this has a irrigation, bottle heights can be 60 to 5 centimeters. You can keep it down when PCR happens and other things changes. So bottle height, whenever you feel chamber is shallow, you can raise the bottle height. When PCR occurs, lower the bottle height, lower the vacuum, lower the power. So these are Phaco tips, 15 degree, 30 degree, 40 degree Kelvin tip. 0 is one complete occlusion, 15 is 90% occlusion, 30 is little less, 45 is cutter, not occlusion much. Kelvin tip gives you both way, side way and this one, but see that when you are starting beginner, that this is not torn, it's not coming out of a hole somewhere else. And 30 degree has been accepted universally, mostly by people, that and Americans throw every tip after every use, they throw bottle after every use. Every AIS also recommended that one bottle for one patient, no evidence based. It is not evidence based. I told people that does water goes to the bottle back ever in Phaco? From the eye or from the tube? Never. It just cannot go to the hanging bottle which is hanging there. So why you want to change bottle in every patient? I don't know why this recommendation came, but this recommendation of AIS and this is recommendation that you must use one bottle for one patient. Americans say one tip for one patient, and they really throw one tip after one patient. And you must slide tip after every surgery, which none of us does. So what I do is I put the Phaco here and I put the spirit swab around it till next patient. That is what I do. So I don't change the tip or anything. Again, use the ideal
you
something.
need to change the tip, sir. You should have different set of tips. Please don't.
Please, you have na Guru Nanak Eye Center have so much money. Kejriwal gives you everything. We don't get anything. Like, Kejriwal gives the free everything. So Phaco power is frequency plus stroke length. Frequency plus stroke length. Phaco power, most of you may not be knowing that when I asked in a big hall few years back, the big surgeons also, how much is the 100% power the Phaco tip will enter the nucleus? Mostly somebody say 1 millimeter, 2 millimeter. 100% power means 0.1016 millimeter. 100 powers means it will go 0.1016 millimeter. So think of 50% power, 30% power. So it virtually goes very little inside that. Only thing it goes again and again so that it deepens it. But so 100% power is that. And these excursions which are told here, still no machine can vouch that what I am writing on this machine, this is this. The frequency varies between 28,000 to 40,000 per second. So, and this is 100% power. You take the hammer from 100% power and 30% power. So 30% power may not break it completely, 100%, and this is the cavitation effect. So two ways Phaco works, cavitation and jackhammer. So jackhammer is Phaco power, and cavitation is when this tip goes and moves, it produces vacuum. and then there is a vacuum, means lot of fluid comes and break the nucleus. So this is cavitation. तो ये चूहा जो है cavitation कर रहा है, and that is jackhammer. Small 30%, 100%. So that breaks it. And cavitation like rat does. So that is cavitation. So the two-way Phaco machine function. And the torsional Phaco recently has come where you possibly have less chattering, that your pieces would not run away if you move it side to side. So it's moving side to side, so it will catch all the pieces. So that is advantage of the oscillation or torsional Phaco, which came in the Infinity, which has come in an AMO also now. And power modes can be continuous, linear. There are pulses which are off, on, 50, 100 millisecond on, 50, 100 millisecond off. That is the Phaco power. The pulse. Burst is that when you start so many pulses together. You started with 5 pulses, then it became 6, 8, 10, this, and then it become burst. So this diagram will show you. Hyperpulse is small duration, so many pulses. Hyperpulses. So these are the various kind of energy which can be delivered. And in whatever machine you have got, they have got it. You can do it. You can use it according to your requirement. You customize yourself what you want. Continuous power, fixed mode, and linear mode. ऐसे शुरू करोगे बढ़ता जाएगा. So suddenly pedal पे नहीं दबाना चाहिए कुछ भी. Start with a small and go down slowly. Intermittent power is on and off. Reduce the Phaco power. It's a pulse mode, 30 pulses per second. Hyperpulse is many pulses per second, but छोटे वाला. So burst mode, hyperburst mode, these are all kinds of energy that you, all purpose is that you break the nucleus with minimum power and then use the maximum vacuum to take it. And surge control is the only thing comes there. So there is a, see now, this is keep on moving and then keep on sucking it. The machine senses when Phaco tip is nearing occlusion. It sends a burst of energy to prevent total occlusion and allows lens matter to adjust and continue flow into the tip. So these are the newer machines which are safer because of their own sensory method, own reading what is required, and they do themselves, the machine do that themselves. That is the safety of the costly machines. But again, your Indian mind adjust with the local machine, these smaller machines also. The outflow is, you can set 25 to 40 centimeter per minute, vacuum 0 to 600. So basically trenching you require less. Everything will tell you that. Rise time is when it takes time to reach that power. So that is rise time. It's a teaching like basic teaching. Followability is that you want these pieces to come towards your tip. So you will increase the outflow. Pani ज़्यादा बाहर जाएगा तो they will tip. These pieces will come towards your tip. That is followability. I think this one also shows that. So these small pieces of that day we have peanuts only we thought. And small pieces, if they have to go more in, then you have to flow out more. If water flow will be more through your tip, then these pieces will come towards your tip. That's it. So that is followability. And this is fluid inflow, outflow, balance. This is a physics formula. I need to not to go into details of this. Inflow, outflow depends on the caliber of the tubes, power, anything, so many things, bottle heights. So surge is basically that, then when this piece goes into this tip, then suddenly this tube opens up. And then you have the collapse of the chamber, that is the surge.
Sir, thoda
faster? Please, no, sorry, no. चल रहा है कि नहीं चल रहा? ये दिखाया piece है, let's see that is working or not. How to reduce surge? एक मिनट जैसे surge reduce करने के bottle height, the tubing should be non-compliant with the rigid tubes, and there are machines which give the venting, that when it is about to go, piece go about to in, it sends the fluid through the system or air through the system. And mine is, of course, surge control is by anterior chamber maintainer of 300 rupees, which will keep the chamber deep all the time. So any hard cataract I am doing Phaco, I'll use the anterior chamber maintainer to keep the surge control. So modulation power, customize yourself. This is my way of Phaco 1. I use 40% power, flow 25 cc, vacuum 50 millimeter when I am making trench. When I have made a trench, separated two pieces, I bring one outside, one in front of me, pulse, 40% power, flow 34 cc, vacuum 400, now I take 500, mostly, always. And Phaco 3 is again, when your mostly pieces are eaten, then you have just small pieces remaining of the cortex or epinucleus, then you have Phaco power 30%, pulses, flow 25 cc, vacuum 120 mm. So, conclusion is proper case selection, surgeon comfort and everything initially, how you use. Thank you very much. Thank you. Thank you.
Thank you very much, sir. It was a wonderful presentation as always, and has benefited really almost half of North Indian surgeons right now, because since last 50 years, sir has been teaching, doing wonderful job. So now let's move on to the next topic. So as we have discussed till now that SICS can correct toricity by choosing correct location, length and shape of the incision. But can it give a multifocality? Yes. A recent, this thing has been very recent. Since last 4 or 5 years, many of the SICS surgeons are trying this. There has been a group on Telegram and WhatsApp where we are discussing this, and still not very conclusive, but yes, few are getting results. I am one of them. Many are doing. So let's start with this March 2019 data. So right eye, patient had 3-meter finger counting vision. We did surgery of right eye by a smart topical SICS, and on 6th April, it is 6/6 and N6 with a monofocal lens. This is possible. You can try this. Let's use it as a spark, to let innovation sink in this SICS, because innovation can only push us forward. So what is the hypothesis? The hypothesis is the cornea is an inherently unstable system with a vertical meridian at higher stretch than horizontal. So while we are doing the third plane of the sclerotunnel incision, we are making a viscous stretch on the horizontal to make this cornea a spherical system. So that kinds of take care of the astigmatism also and induces multifocality. The exact mechanism by which the multifocality is achieved is not very clear. People are doing it, and we are in the process of trying to find out how it is being done. So let's start how we do it. So again the same thing, using Ranjan marker, the incision on the sclera. This all is absolutely same as we do for all SICS. The only smart step is the third step where we enter the eye. So the earlier what we used to do, we used to have a keratometry, this keroscope, which gives the inner 3 rings we have to see. If they are perfectly circular, we move ahead and make a small entry in the middle, then go with a curved cannula and stretch cornea horizontally. Check again with keratoscope whether the Myers are now circular or not. and then move ahead. So this takes a lot of time. It requires a lot of patience also, and repeated visco stretching is required. So surgery becomes little lengthy, but yes, the time of surgery is, I think, should be the least priority for a surgeon. They should give a good result. So this is how a smart incision is made. And at the end of this incision, the cornea mire should be perfectly circular. Now what has happened, the doctor who was doing it has got a software, and now with the help of software, you don't have to put this keratoscope again and again. Now the software will tell you whether it has become circular or not. So Dr. Rajiv Raut, who practices in Pune, is doing this surgery exclusively for his patients and getting good results, as he's claiming, and many of us are doing and getting results. So see, now the software is telling you where to stretch. There is an audio also to stretch at this axis, this axis. And so at the end, you will achieve a circular cornea, and your entry becomes like that at the end of it, the cornea becomes perfectly spherical. So this step actually takes a lot of time, but I think worth trying. Must do at least in 50 patients, and then you will see the results. So that's all. Many are doing it. I just wanted to show that people are doing it, and it has become a kind of rave in certain SICS community. So that's all from my side.
Thank you, Dr. Ranjan. I think we have Dr. Samar Basak lecture, so you will also do it faster, whatever you are doing.
Sir.
Because Samar Basak will give us many, many more teachings.
Sir.
Please, thank you very much. The smart incision, I don't want to comment. Just smart SICS.
Yeah. Thank you.
Aniket was in the video now when we started how to sit and how to get up and how to adjust the seat. He was the student. Now he is a femtosurgeon.
Thank you, sir. Thank you, Pratyush, for including me in this IC. So I'll be completing the journey which we started with ECC now. And we all know now that cataract surgery is rapidly being transformed into a precise refractive surgery. And premium IOLs actually includes any non-conventional monofocal and presbyopia correcting IOLs. Let's pay tribute to Sir Harold Ridley for one of the most important developments in the history of cataract surgery for the patient, basically, than us. And the ideal intraocular lens should actually restore vision at all distances, especially now with smart dashboards, computers, tablets, mobiles. Our intermediate distance and near distance has come more into prominence. So traditional lenses, the best case scenario was that it was good for vision, for distant vision, whereas an excellent option for patients from 45 to 60 is when they want distance for intermediate and near. And that is why these days most energy and funding is probably on the development of new and complex IOLs. For the premium IOL technology, the biomaterial used should be compatible inside the eye and also for the capsule especially. Hydrophobic acrylic material present the highest level of adhesiveness and also expected that the anterior and posterior capsule fuse with the IOL and prevent decentration, which is important. The square edge of the optic in the premium IOL are designed to prevent capsular opacification. The toric IOLs with a larger overall diameter eventually have a good rotational stability. Aspheric IOLs which match more closely to the shape and optical quality of the human natural lens and provide better vision quality. And therefore some authors even include monofocal aspheric IOLs also as a premier IOLs. Premium IOL basically implies an aspheric IOL with different optical characteristics to correct the accommodation and also the astigmatism. So the premium IOLs include toric IOLs, multifocal IOLs and accommodative IOLs. We'll discuss today more about toric and multifocals which I am practicing. Approximately 1/5 of our patients have an astigmatism more than 1.25, and if you take more than 1, then it becomes around 30% of the population. So the different cylindrical correction range is present by different companies. Platform, it doesn't matter much. Over a period of time, it's come to know that both provide quite equal rotational stabilities. The vast majority of the patients, in fact, do extremely well when careful attention is paid to the patient, lens selection, the surgical technique. Of course, in patients with IOLs, misalignment is an important factor. Studies between 2 to 10% have shown to have a rotational instability. It can be a result of improper alignment during surgery or also post-op. Multifocal IOLs are classified according to the optical principle that it serves basically refractive multifocal IOLs on the refraction principle, diffractive multifocal IOLs on the interference and optic wavefronts. Refractive multifocal IOLs, they have different annulus designs from center to outside, one for distance, one for near with an aspheric design. And a rotationally symmetrical refractive multifocal IOLs that are presently present in the market are Array and Resume. And this is a rotationally asymmetrical IOL where the near ad is on the inferior half. One of the limitations of refractive multifocal IOLs are, of course, because it has to be placed in some particular order, it's pupil dependent, a high sensitivity of lens centration, and the usual problem with all multifocals because the light rays are divided. You have halos, glares, and loss of contrast sensitivity. Diffractive multifocal IOLs are a combination of a monofocal optic and a diffractive element. We all have a monofocal optic that gives a basic power for distance. We have a diffractive that divides the light into distance and near. And when you combine this, then you get something called as multifocal IOLs. Diffractive multifocal IOLs that give either a bifocal to near and distant, or if you add an intermediate, it becomes a trifocal. So most of the light is deviated for distance and near, and approximately more than 20% of the light here is lost. And that is why we have loss in contrast sensitivity in most of the multifocal IOLs. The width actually governs the addition for the multifocal IOLs. There's a concept of apodization where as you go toward the periphery, the height of the steps starts decreasing. So the purpose for that is when the pupil dilates in the mesopic conditions, it becomes a near distant IOL with not much loss of contrast and a good halos and control over halos and photic phenomenons. So these are the diffractive bifocals that are present in the market. Trifocal IOLs, you take two bifocal IOLs, one for distance near, other for distance intermediate, and it gives you third point of an intermediate IOL, intermediate point. So these are the different trifocal IOLs that have been present in the market. To add to that, to add a continuum of foci through the implementation of spherical aberration, basically in the presence of these to have a continuous transition zone instead of three different points, you have the EDOF IOLs or the extended depth of focus. And as an extended depth of focus is created, the quality of intermediate vision, a light diffraction that elongates the focus, gives a continuous vision. These are the extended depth of focus IOLs that are present. So this is what are the multifocal IOLs, your bifocals, trifocals, and extended depth of focus. But do they really work in the eye, as claimed by the people there? So this is where the defocus curve comes into picture to tell us about the expected visual outcome of an IOL. So if you take into consideration a young adult with less than 30 years with crystalline, you have a good vision for far, intermediate, and near. Whereas if you take monofocal IOLs, excellent vision for far, and as you keep going away, then the distance and then the vision becomes poor. A bifocal IOL usually has a V shape of the defocus curve, good far, poor intermediate, and a good near vision. This is where trifocal IOL comes into existence. The good far, decent intermediate that helps you at around exactly at 60 centimeters to 80 centimeters, and probably an expected near vision we should be satisfied with. When it comes to EDOF IOLs produce a smooth, uninterrupted and dome-shaped defocus, and they have an intermediate vision which is slightly better compared to a trifocal, but it loses on when it comes to a near vision for trifocals. So this is what is to summarize. The trifocals and EDOFs have a better intermediate vision, and EDOFs have a better intermediate vision in mesopic conditions. Near vision is better with bifocals and trifocals. And of course, contrast and optic phenomena is something we all have to deal with, even with newer trifocals, though they are less, but they are still present, and people do adapt after a period of 1 to 2 months. Some studies have showed better contrast with EDOF compared to trifocals, but others have found it equivocal. We all have to bear with glare and halos. This is something that is more common with bifocals and trifocals because that is a property of interference and diffraction you can't go away with. Coming to patient dissatisfaction, if you see the most common point is blurred vision and ametropia. You have to have a very good pre-op evaluation so that you give emetropia for distance. If you give emetropia distance, then rest of the focal points are taken into considerations. I'll quickly go to my second part, which is flax. Yeah. Yes, sir. Yes, sir. Dr. Samar Basak is waiting, so I'll just rush through my slides. Just a couple of videos. Yes, sir. 5-10 minutes. I'll just finish. Small. 2 minutes. Yeah. Just 2 to 3 minutes. That's it. Yeah. Dr. Samar Basak, just a couple of minutes. I'll just. Yeah. Sorry for making you wait. So this is a new addition to our cataract armamentarium. That is femtosecond laser-assisted cataract surgery. These are a few of the features which everyone knows. It acts as a laser blade basically, causing photo disruption and dissection. Multiple commercially available in the market. We at our center have Lensex. So this is a platform that's got a good imaging system, a patient interface, a femtosecond laser. Earlier lots of contraindications which have slowly become possible now with the advancement in technology, but still some contraindications remain. And femtosecond laser assisted gives precise and reproducible results with compared to capsular access and lens. So these are a few of the things that are to be done. Docking is something that is important because you have to centrate the eye. That is when next steps becomes easier for you, basically the capsulotomy and the lens fragmentation. This is how the OCT comes, live OCT. This is a live OCT, 3D OCT. This is nothing of a animated part. It gives you a real-time OCT right from the anterior surface of the cornea to the posterior surface of the lens in one picture from top to bottom. And sorry. Video is not playing. Sorry, ma'am. Yeah. I even don't know where I'm. वीडियो है प्ले yeah. So this is how it appears when you are doing it live. You got the capsular access size, the fragmentation size, the placement of the incisions, and once everything is decided and we start the application of laser, then you have the first capsular access, perfect central capsular access, then followed by the lens fragmentation. You can have either a French fry cut, a pizza cut, whatever you want, so that it becomes easier for you. Then after this, then you have the incisions, the main incision, followed by the 2 side incisions. If you have planned an LRI, then it gives a precise LRI. And just a video to show. Excuse me. Switch on. Play नहीं हो रहा है. Yeah. This is just to show how easier it becomes to take out the capsule. You just have to use a capsular access forceps and drag it out. And then when you begin the Phaco process, most of your chop is already done. You have to just slightly separate it at the place where there is dissection, and then most of the pieces come to your probe directly without even bothering to chop and go anything deeper further. Especially, I'll just try to wind this up now. Dr. Basik is waiting, especially in case of hard cataracts, subluxated cataracts, intermittent cataracts, cataracts where you feel that you want to use special instruments, CTRs, capsular hooks. So once the capsular access is done in a subluxated cataract, it becomes more easy to use all those things. And we talked about the premium IOL, where it is more important to have good centration, good IOL stability, and that is when, if you combine with the flax, it gives you excellent results. Thank you.
Thank you, Dr. Aniket. It was a wonderful presentation. And now, Dr. Samar Basak, who is director and founder member of Disha Eye Hospitals, a well-known researcher and a cornea trainer. He is a Southeast Asia cornea trainer by the Cornea Society of America. So, sir, I would like to invite you and to deliver your talk.
Thank you, Pratyush. And just you have seen beautiful videos and beautiful surgeries. My talk is on once-a-day Nepafanac for managing post-cataract surgical inflammation. I do not have any financial interest. You know that in last decade, we had tremendous growth in cataract in India, and last year we performed close to 7 million cataract surgery. But all cases, our aim is to give best undercorrected visual acuity, comfort, recovery time, and reducing the risk of complication. So we need actually choose the appropriate therapy. There are two main concerns after cataract surgery. One is infection, another is inflammation. And you know that the risk is 1 to 2%, and there must be addressed, otherwise there will be suboptimal visual outcome. If you consider the pain, pain is also a concern. Like 1 hour after surgery, 6 to 95% of our patient complains of pain. 1 day post-op, 3 to 52%. After 1 week, it is 2 to 26%. So post-cataract surgery, pain and inflammation, does it happen despite advancement of in Phaco like flax surgery? Yes, it does happen. And there are many multifactorial causes, and you know that this is due to whatever method you have choose. This is due to breakdown of blood aqueous and blood retinal barrier. Normally, this breakage causes inflammation, which reaches peak at 5th day and decreases over 2 to 3 weeks time. So with topical steroid, we notice that most of the eye, there is no inflammation by 3rd week. Diabetic and uveitic patients are more prolonged post-operative reaction because of they have their compromised blood aqueous barrier. So conventional versus flax, there is evidence of increased inflammation, and there is increased prostaglandin concentration, and mean aqueous flare is more than conventional. This study has been published in American Academy of Ophthalmology journal, meta-analysis of huge number of patients. What about CME? If you see the list of CME, initially it was very high in our ICC era, and now it is with Phaco or flax, it is between 1 to 2%. Either you do define with OCT or clinically. So again, the pathogenesis not completely understood, but there are two pathways. One is the lipo-oxygenase pathway, another one is cyclooxygenase pathway, COX pathways. And again, the disruption of blood retinal barrier is important. And you know that there is perifoveal capillaries and fluid accumulation. So there are two agents when we treat post-cataract patients. One is steroid, another is NSAID. So you have two arms, two different mechanisms. NSAID more on cyclooxygenase pathways. Steroid is required because in some of the cases it is because it gives maximum anti-inflammatory effect, and there is a consensus that many people start with steroid drops, then they switch over to NSAID as a maintenance dose. Then topical NSAID is important because there are several studies which shows that it reduces post-operative inflammation and also the CME incidence. And you know the advantage over steroid. Main advantage is the intraocular pressure rise and intraoperative miosis prevention and reduction of postoperative pain and photophobia. There are several studies on it. There are several randomized control trial, like 48 randomized control trial. There are several studies, NSAID alone versus steroid alone, NSAID plus steroid versus steroid alone, all this combination. If you see the list of NSAID, Nepafenec score is higher than bromophenec, Ketorolac, and diclofenac. And we know that NSAIDs is not, I am a cornea person, so I know that it is not good for compromised ocular surface. So you have to be very careful. But several studies have shown that Nepafenec is least toxic to the human corneal epithelial cells. And there is also concept of selective versus non-selective NSAID. So there are two COX inhibitor, COX-1 and COX-2. COX-2 is more with analgesic property. So if you have a NSAID with is more COX-2 and less COX-1, probably that is good. So Nepafenec, it is the prodrug, Amphenec, and you know the same mechanism of its action. So it is higher affinity towards COX-2. So this is a new kid in the market, Ilebro. Nepafenec, I first says that I do not have any financial interest. It is 0.3% suspension, new kid in the market, whereas what is available till last 5-7 years was Nepafenec 0.1%, and the content is 3 ml. What is difference? It is once a day posology, and if you see the how it is dissolved, it is dissolved in guar gum. What is guar gum? Same as Cysteine Ultra. What is that? HP guar, same thing with a higher concentration. What is that? It is advantage. We know that what is Nepafenec, it is a better penetration, target specific, better bioavailability because it is 0.3%. And what is the dose schedule? 1 drop OD, beginning 1 day prior to surgery, continued on the day of surgery, and maybe this is the typically it is given in their leaflet inside the box, and additional drop may be administered 30 to 120 minutes before on the day of surgery. Typically it has to be given on bedtime because it is highly viscous and patient may not like it causes blurring. There are several studies on 0.3 versus 0.1, and a lot of studies are there. They have assessed the pain, inflammation, and control all these things. Then the efficacy, both the primary efficacy is the inflammation and also the one to see the pain score. And all these things, like they have 0 cells and 0 flare at 14 days compared to 0.1%, and pain score is also less. Safety, it is highly safe, and across the treatment they have huge data, and only 3 patients had problem. 1 patient has hypersensitivity due to Nepafenec itself, and other 2 patients with vehicle, and they have complained. And all 3 actually had non-serious side effects. So there are also studies on flax and this 0.3% Nepafenec eye drop. and it has contained also back. Back is useful because of good penetration, because it is once a day. It enhances the drug delivery through cornea. Its pH is 6.8, again acidic, again which is incorporated purposely to increase the penetration of the drug through the cornea. Can you use NSAID alone postoperatively? The answer is yes. There are several studies, and probably we can use NSAID alone in some of the cases. The routine cases, yes, 0.3% such suspension, and this is actually happening where there is no problem, actually routine, no complicated cases, non-diabetic cases, but where there is high-risk cases like post-uveitic cataract or patient is having long-standing diabetes, you have to use prednisolone acetate or some form of cycloplegics. So my routine after introduction of this month, three months, my preference is like 48 to 72 hours before I give 2 drops, Moxie and Ilebro at bedtime. I ask the patient to continue the same treatment, same vial till the last day of their protocol, and on the day of surgery I just ask them to put 1 drop before coming to the hospital. Then post-operatively, typically I end the Moxie by 7 or 14 days and Ilebro for 3 weeks. This is my routine in 90 to 92%, but however, high-risk cases, as I said, that this is to be addressed. So still so far, it is more than 600 now. This is last week data. So follow-up on after day 1, there are some patients with 2+ cells and flare, but day 7, where we are clearing the patient, 2 patients at cells, 2 patients at flare, 3 diabetic patients, additional steroid drop given, and at 4 weeks, there is 0 cells and flare. And I call that because I was in a part of their study, so I call the patient, 200 patient, after stoppage of the drug, typically 2 weeks, and I have not seen a single rebound phenomenon of inflammation. And some of the patients are bilateral sequential surgery within 3 days or within 7 days. In one eye, patient was getting Nepafenac 1%, another eye patient was getting Nepafenac 3%. And patient always says, oh, why you are not giving that, why you have not given that drug once a dose initially. There are other studies in the pipeline. If you see that, there are studies like post-PRK, post-refractive surgery, then also diabetic retinopathy, cataract surgery patient with diabetes, all randomized control trial. And also the patient after intravitreal injection, they are giving just 1 drop of 0.3% Nepafenac. So in summary, Ilebro, Nepafenac 0.3% play important and crucial role in managing inflammation once in a bedtime, vis-a-vis what is 3 times. It is very patient-friendly, compliance, and it improves the, also reduces the cost of treatment. Normally we give 2 vials are required, here 1 vial is sufficient, and additional steroid if required. And it is very useful in steroid responder and glaucoma patients, and in many cases of uveitic patient, it has a high safety margin. So you can continue with Nepafenac 0.3, 1% for maybe 3-4 months. Thank you very much for your kind attention.
Thank you very much, sir. Now we would like to have a group photograph.
Dr. Samar, just one question about that. Your basic patients, all of these, same kind of surgery, same kind of surgeon,
Same. I am the surgeon.
For your how many? 200 patients, 500 patients.
600 patients. I am about surgeon.
Then compare it with like somebody in district hospital, somewhere else.
Same group, other hospital, they are now mobilizing to me.
No, what I'm saying that what would we recommend to people who say long time in doing surgery, there's a lot of virus handling.
Those are very important factor. What you are telling that you know how good you surgeon, and you know how you have done your surgery. So if it is a uncomplicated, clean case, where you know that it is a 4 minutes job, 5 minutes job, you have through. Routine cases, you give, I don't give steroid. For last 5 years I am practicing this. 5 years only Nepafenac, that time 3 times, but again compliance was issue because the old lady at home alone, so who's giving the second dose at daytime? Nobody is there at home.
No,
But
I
this-
also believe that reduce the drugs numbers, reduce the
Yes,
timings
compliance,
and other things.
compliance.
Compliance is a must thing, like I know that very well. The good thing that if it really works,
Sir,
great.
have you used any other brand, like it's something like using a Moxiflox of, Vigamox, and have you used some other brand also? Is it available?
Moxie.
With
no,
the
no, no.
antibiotic.
No, I am talking about this only.
This other brand, I don't think it is available at this point,
0.3%.
0.3%. I have a very, I mean, I am obsessed with that kind of thinking that if you use that cataract surgery 1 time in a lifetime, 2 eyes 2 times in a lifetime. So you have got 2 chances. Why you are thinking of other company? Those who are generic drug from their factory, use them. I have that kind of feeling. So you will not get a second chance.
Because I read that in America their drugs are so costly that they are giving now those kind of dose that just 1 dose is enough forever, for many days. Those kind of drugs they are making.
Yes, sir. Sir, you know the cost of this medicine is in America, Ilebro, that to 1.7 ml cost is $580. And cost of 3 ml in our country, it is 340 rupees.
We have got really good cheap drugs,
And
very good.
Nepafenac, previous one, it is 220. So patient is still, that 100 rupees is nothing, but compliance 3 times to 1 time, it is very big gainer in it.
Great. Only thing is just that really standard surgery.
Standard surgery, that is the basic key. Everybody, here everybody is showing the standard surgery. No, complicated is complicated. There the protocol is totally different. Thank you, sir, very much.
Thank you very much. Okay, bye.
Sir,